Good morning. This is Melody Pazalt from the Healthcare Authority and the Division of Behavioral Health and Recovery. We'll get started in just another minute as folks get logged into the webinar. Thank you so much for joining our monthly Criminal Justice and Behavioral Health Interface series. And again, we'll get started in just another minute.
Melody, this is Kim. I realize I haven't shared my camera. Is it better? And if I do, will they be able to see my shared screen and my camera?
Yes, they should.
Okay.
And it's totally up to you. Oftentimes the camera can take up bandwidth. And so, so it depends on kind of how your bandwidth is.
Okay. All right. I'll start with my camera on, and then maybe when I switch to presenting, I'll turn it off because I'm not sure how trustworthy that is. Okay.
Good morning, Kim. Good morning, Dr. Mosh. Again, we'll get started in just another minute as folks are logging into the webinar. So good morning, my name is Melody Pazalt. I am a section manager at the Healthcare Authority and the Division of Behavioral Health and Recovery. Several months ago, our divisions within the Healthcare Authority started meeting to talk about all of the different programs and services that are helping individuals that have behavioral health conditions and touch the criminal justice system. And we were learning so much about each other and all of the different divisions within the Healthcare Authority that we learned that there was a lot of other programs happening in the communities that we wanted to learn more about all of those different programs. And so we started a webinar series in January that meets the last Wednesday of every month from 8:30 to 9:30. And this morning, we're very pleased to have Dr. Donna Mosh and Kim Mosef presenting on the Trueblood Contempt fine projects. Just a few housekeeping items before we get started with our webinar series. It's always a good idea to close your windows if you're not familiar with the GoToWebinar. If you do want to ask questions verbally, I suggest that you call into the webinar, and you should have on your menu an option to either choose your audio or choose your telephone or the computer speakers. If you choose the telephone, you'll receive the dial-in information, the access code, and your PIN. Just a disclaimer, this webinar is being recorded and we will be posting this to the Healthcare Authority website. We're actually in the process of building a page that shares all of the links to the webinars that we've been hosting for the last 5 months, as well as information about some of the programs that the Healthcare Authority operates that intersect with the criminal justice system. Again, since this will be open to public disclosure, please don't disclose any private or confidential information. Just some links, and we will send these webinar slides out to everyone. But if you're interested in the previous webinar series that we've held, we started out in January with an overview of the sequential Intercept model. In February, we had an overview of the prosecutorial diversion programs that DSHS and King County operated. We also had the law enforcement assisted diversion program in March, and then last month was the Washington State co-responder program. Again, if you're not familiar with the webinar, the GoToWebinar controls, you have this little menu bar with the little orange arrow. This allows you to expand or contract your GoToWebinar menu. The audio pane allows you to choose either the computer audio or your telephone. Again, we get less feedback if you want to ask questions verbally by choosing the telephone number. If you want to ask questions, you can also raise your hand, and that way we can call on you and unmute you. You can also see who potentially is on the attendee list by clicking on the attendee menu. And then if you want to ask questions by typing in your question, you can also do that in the question pane. So I'm going to turn it over to, this just is another slide on how to raise your hand. I'm going to turn it over to Kim, and while we're doing that, I'm going to read their bios. So Kim, I'm going to turn it over to you. So Kim Mosif is the Director of Disability Rights Washington's Treatment Facilities Program, working on behalf of people with disabilities in hospitals, residential habilitation centers, nursing homes, and assisted living facilities, among others. As class counsel in the AB versus DSHS, aka the Trueblood lawsuit, Kimberly also works to reform the forensic mental health system in Washington and to expand diversion opportunities for people with behavioral health conditions who are facing arrest and prosecution. She has also worked to reduce the use of force by police against people with disabilities. Before joining Disability Rights Washington, Kimberly practiced law in New York City, where she worked on behalf of parents caught up in the child welfare system, people receiving governmental benefits, sex workers, and people with mental illness. Kimberly was born and raised in Seattle, Washington, and she is a graduate of Columbia. We're also joined by Dr. Donna Mosh. She is the president and CEO of Massachusetts Association for Mental Health. Dr. Mosh brings organizational leadership, operations and management, evaluation, research, and strategic consulting experience gained in private and public sector enterprises to inform her public policy, knowledge, dissemination, and legislative advocacy work for the Massachusetts Association of Mental Health. Her prior service in the private sector includes 10 years as Senior Fellow, Principal Associate at Apt Associates. Dr. Mosh worked on behalf of foundations and governments and provided policy, evaluation, and implementation assistance addressing insurance, service delivery, and financing reforms targeted to individuals with complex health risks and disabling health conditions. Skilled in linking large data sets to advance accountability, clinical, and cost improvements, she contributed to designing system solutions for government, clients' compliance, and legal regulatory reforms. Prior to joining APT, Dr. Mosh was Chief Administrative Officer for Comprehensive Neuroscience Incorporated, founding president and Chief Executive Officer for Magellan Public Solutions, and founder and president of Integrated Health Strategies Incorporated. Dr. Mosh has a long career in public service. She presently serves as court monitor for the U.S. District Court of Western Washington, addressing forensic service reforms at the junction of the health, disability, and justice systems. Dr. Mosh's prior service includes Special Master for the U.S. District Court of the District of Columbia, Executive Director of the Rhode Island Department of Mental Health, Retardation, and Hospitals, and Assistant Commissioner of the Massachusetts Department of Mental Health, overseeing the divisions of mental health, substance abuse, and forensic medicine. Her population-focused work addresses a broad range of at-risk and vulnerable groups of children, adults, and elders, including persons with autism spectrum disorders, behavioral health condition, HIV/AIDS, multiple chronic conditions, criminal justice involvement, military and veteran status, and homelessness. Dr. Mosh is a published author of government and foundation reports, book chapters, and journal articles on the organization, financing, and delivery of care to vulnerable populations. To support health promotion, illness prevention, and early intervention, she has served as a volunteer officer of several governing boards, including a regional health conversion foundation, a national youth development and prevention organization, and urban elementary and middle school and state healthcare reform initiatives. Dr. Mosh holds a PhD in social policy from the Heller School at Brandeis University. We are so honored to have Dr. Mosh and Kim present this morning. Thank you both so much for your time, and we look forward to the information.
Thank you, Melody, and thank you everyone for attending today. This is exciting. I am always happy to talk about the diversion programs, and I think if any of you have attended the previous webinars that Melody listed, you'll have some familiarity with some of the programs that we actually discussed today, and certainly the framework of a lot of our diversion programs. So just to double check, Melody, you can see I'm sharing the screen and the PowerPoint's up.
Yes.
Okay. Okay. So today we had just a few presentation goals on agenda. We want to make sure that we explain what the AB VDSHS case is, which we'll refer to today as Trueblood. It's more commonly called Trueblood. It's a class action, and we're going to talk about who the class members are. We want to make sure we describe the genesis, funding, and structure, and the monitoring of the diversion programs that are funded through the Trueblood case. We want to highlight the work of the Trueblood Diversion Program providers that are statewide, and we want to discuss the next steps as we are approaching the end of the grant period for these Trueblood diversion programs. And I am happy to take questions throughout, though I'm not sure, Melody, if you prefer to wait to the end.
We can, if folks want to tap their chat questions into the question pane, I can certainly see as things come up. And then again, if folks want to raise their hand, that will be an indicator that they may have a question.
Great, feel free to interrupt me. Okay, so we will start with talking about the AB VDSHS case. What is competency in the criminal process? Some of you may know this well already, so bear with me, but a defendant in a criminal case has to be competent, legally competent, before standing trial on criminal charges. And that means that they have to have a reasonable degree of understanding of the nature of the criminal charges and just the whole process of being on trial. And they have to be able to communicate with their defense attorney and assist in that defense. So oftentimes the questions of your legal competency are raised early on in the proceeding, and I think most commonly by your defense counsel, but it can really be raised by the judge, by the prosecutor. And if questions are raised, the court can order the defendant to undergo what's called a competency evaluation. And that can occur either in jail, if you're being held in jail, or it can occur inpatient if you have been, you could be moved into an inpatient healthcare setting for that evaluation. And then separate from that, it can also be raised and you can have an evaluation if you are released pending trial. But as we'll talk about, the Trueblood case is concerned with those who are in jail or in inpatient settings and receiving those evaluations. So DSHS is responsible for providing those evaluations in Washington State. Once the evaluation is done, the results are presented to the court, and if the defendant is found not competent to stand trial, the court has to pause the proceedings and can order that defendant be restored to competency. So we'll talk about what we call restoration services or restoration treatment today. And those are provided at an inpatient setting, usually at a treatment facility. So in Washington State, that's Eastern State Hospital, Western State Hospital, or the three alternative sites, which are the Yakima Competency Restoration Center, Maple Lane, or most recently, the Fort Steilacoom program, which is on the campus of Western State. Or that it can also occur in an outpatient setting. Restoration can occur in an outpatient setting, meaning in the community. And Washington State has not seen that in any organized fashion, at least to my knowledge, but that will actually be rolling out in some regions of the state soon. So the case itself, what was going on and has been going on for years in Washington is that people were waiting for weeks and often months in jail to receive competency evaluation or transfer to the hospital or healthcare settings for a competency evaluation. And then if they were found not competent to stand trial, they were waiting even longer to transfer for restoration treatment. So essentially people were waiting in jail for these services and we're not doing well. Often people decompensate when they are sitting in jail. They're usually oftentimes placed in solitary confinement. They're not getting access to significant mental health care, and people were just generally suffering. Jail is not a treatment setting, and I think when we first brought this lawsuit, the jails were pretty much wholeheartedly, I think, with us on this. They did not feel that this was a good setting for folks who had significant mental illness. So people had been waiting. The last lawsuit itself was filed in 2014 by Disability Rights Washington, ACLU, Public Defender Association, and then our co-counsel, Chris Carney. And it was more commonly referred to as Trueblood. Cassie Trueblood was a public defender in Snohomish County who was initially involved in the filing of this case. And her name is now attached to this case. I'm not sure how she feels about that, but we filed in federal court. It's a federal class action lawsuit, and it challenged these, what we argued were unconstitutional delays for folks waiting in jail for competency evaluation and transfer to restoration. So this is a very important piece of information here. When we talk about the Trueblood diversion programs, it's come to mean so much. There are so many services that are under that umbrella and that the case is funding. But at the heart of that, those funds and those programs are meant to serve Trueblood class members and to prevent people from becoming class members. So this definition of who is a class member really is key to thinking about these programs and how they're meant to run and to function. So the case defines class members as people who are waiting in jail for either those in-jail competency evaluation or restoration services. They have one or more of the following conditions that impact their competency. So I think most commonly that's mental health and or substance use. It can be intellectual and developmental disability. It could be a traumatic brain injury or just other cognitive impairments due to age, injury, or disease. And that is affecting their competency and means that they're either waiting for those evaluation or potentially for restoration services. And they can be charged with a misdemeanor, something as small as stealing a bag of chips, to a serious Class A felony. But really, as I've highlighted here, the point I want you to take from the slide is that these are people waiting in jail. There are a lot of people who may be released from jail and waiting for these services in the community. Their charges are pending, they have trial pending, and they're waiting for the evaluation in the community on a separate wait list. But the Trueblood case is really about these folks who are waiting in jail and not doing well, waiting in jail for transfer for these services. So in 2015, after a trial, the court, Judge Peckman and the federal court order required DSHS to provide these competency services within following time limits. So for in-jail evaluations, the evaluations that take place for folks while they're sitting in jail, to determine competency, that's supposed to be within 14 days. And then if they are deemed not competent to stand trial and then ordered for restoration, there's supposed to be 7 days to transfer that person out of the jail and into inpatient care to receive those services. So those are really the key numbers to remember. It's 14 days for in-jail evaluation and 7 days to receive restoration.
Kim, this is Melody. We do have a question from Karen,
Yes.
and she's asking, if a person is not competent at the time of the crime but gets restored, then what happens?
Well, then, right, great question. So, I mentioned that when competency is raised and an evaluation is ordered, they push pause on the criminal case. So your speedy trial rights aren't running. It's essentially everything's in limbo while they're trying to figure out if you're competent for that criminal case to proceed. And so when we're restoring someone to competency, what we mean there is really we're just trying to restore them such that they can be prosecuted. So it's a good point to keep in mind when we talk about restoration services. Certainly there's element of treatment people get, there's medication management, but a big chunk of that is just the person being educated on how the legal system works, how to work with their defense attorney so that they can meet the points I mentioned before on competency to stand trial. Do they understand who the judge is? Do they understand what the point of this trial is? And can they work with their defense attorney in presenting a defense? So if they receive restoration services and they are evaluated again and someone decides, okay, now they're competent, they essentially might return right back to jail and then that criminal case can proceed again. I hope that answers your question.
And
Oh,
I do want to check. Malia has her hand raised, so I'm going to unmute Malia and see if she wants to ask her question. Malia, go ahead. Oh, she might be just practicing raising her hand. Oh, and Karen said thank you. And we have another email from our question from Joan, who says, what services are included under the title Restoration Services?
That's another great question, and I think Dr. Mosh will be able to speak to that perhaps a little more, but Washington State uses a particular curriculum called the Breaking Barriers curriculum. And so it is a curriculum. It's essentially educating folks in, you know, who the players are within the criminal court system and making sure they understand that, and making sure they understand what the criminal charges are against them, and how to work effectively with their defense counsel. So that is a big part of getting restoration services. Oftentimes it also includes medication. And people are moved, into a treatment setting, which is much more therapeutic and promotes, I think, health and well-being, much more so than sitting in a jail cell. But I think Dr. Marsh will have more to say potentially about what our particular restoration services are. And I did want to just add to my prior answer that I think the question had been, what's the difference potentially of being not competent and maybe what at the time of that the crime was committed. There's a separate question as to whether the person has the necessary mens rea to be prosecuted and found guilty on criminal charges. So someone could have been of sound mind, committed a crime, put in jail, they have criminal charges pending, and then they develop mental illness or some other symptomology such that their competency is questioned. But it's a separate question as to whether they were of sound mind at the time of the crime. So it's two different legal questions: whether you can, you at the time of the crime knew what you were doing and can be prosecuted there, versus whether at the time of the trial you understand what's going on. All right. So 2015 was the court order. And I'm going to turn it over to Dr. Mosh now to talk about what happened after that 2015 court order.
Oh, Dr. Mosh, we can't hear you.
I apologize. I needed to take it off mute. I'm happy to be here today speaking with all of you. We're grateful that so many of you have an interest in the Trueblood diversion work. And I want to thank Melody for her generous introduction, and Kim for really laying the groundwork on the case and the background to this. As Kim was saying, the state was, as a result of the trial, ordered to provide in-jail competency evaluations within 14 days and to provide transfer to a hospital or a residential treatment facility for either evaluation, if someone was too ill to really remain in the jail and be evaluated there, or for restoration once they were found incompetent. And what that meant really is the state needed to hire a number of clinicians, really trained evaluators who could really be available to timely evaluate people in the jails. And then the state had to bring online additional beds in either inpatient or residential treatment center settings and staff those beds and roll out the program support to enable them to timely admit people for either evaluation or restoration. And the consequence of having to do all that work is that it's taken time, and there have been various hang-ups in the rollout of those activities. And so the state has not, in these intervening years, been able to really hit the court's mark of what it defines as substantial compliance with either the deadline for timely jail-based evaluations or the deadline for timely admission for evaluation or restoration. I will say the state has made substantial progress in doing the jail-based evaluations more timely, so that a majority of cases are now evaluated within the prescribed time frame. But there is still a substantial proportion who are not. And then it's been especially difficult for the state to meet the timeline for transfer to inpatient care because of the state's approach to doing this, which was to develop beds in the forensic hospitals, having to renovate units, et cetera. All of that has taken time. And while it's in progress, it is not complete. So after several years of non-compliance, the attorneys, Disability Rights Washington and Mr. Carney, and the ACLU of Washington brought a contempt motion before the court, and in the course of that also asked the court to impose fines for the failure to be in compliance, which the judge did end up ordering. And as a result, starting about the middle of 2018, that was then about 3 years into the implementation of the case, the state started paying fines to the court, which were calculated based on how many days over a certain threshold patients or class members were waiting either for a competency evaluation in jail or for admission to the hospital for, as we said, either evaluation or competency restoration. And it, as this slide indicates, about $4 million a month was being paid in contempt fines to the federal court. And as of now, the Federal District Court Registry, which is where the fines are held, and again, in control of the court, the state has paid over $85 million into that fines fund. If someone could advance the slide. Thank you. So faced with mounting fines and recognizing that there were many needs that class members had, Judge Peckman ordered that the parties look at how those funds should be distributed. In particular, she asked me as the monitor, and she notified the plaintiff as the party representing the class members first and foremost, that she wanted these funds spent exclusively on meeting the needs of class members, because effectively the fines funds had been accumulating because of a lack of service to those class members or a lack of relief to their claims to the federal court. So we got together as parties and put together something called a Diversion Services Workgroup. And that there was representation from the state of Washington, from the plaintiffs, and from the Office of the Court Monitor. And we began to gather information on services that we thought would meet the needs of class members, but what were not either jail-based evaluation or restoration services, but other services that were actually driving people into the justice system. So we decided that diversion services would be the focus of investment, and we analyzed the peer-reviewed literature and various reports to foundations and government agencies from across the country, trying to identify what would be good practices. We also analyzed data going back several years that described the characteristics and patterns of service utilization of the class members. This would be service utilization prior to their arrest. And we really discovered a number of things that spoke to both the priority needs that class members had and gaps in service available in communities that could help them to avoid encounters with the police, for example, or if they had an encounter with the police, to avoid arrest in jail. And for others, once they were released from jail, to avoid falling right back into difficulty and soon being arrested again because they had no services and starting down the path again to competency evaluation and restoration. So we were trying to both prevent people getting in at the front end and catch people on the way out of the process in the hope of avoiding recidivism. And we used as a framework something called the sequential Intercept model to guide our investments. If you move to the next slide, you'll see an illustration of the sequential Intercept model. And I was explaining before that we were looking at making investments at what on this slide are Intercept 0 and Intercept 1, where you have people who are getting into a crisis, and if behavioral health professionals or disability professionals could intervene rather than law enforcement and meet the client's needs, you might avoid it rising to the level of attention from local law enforcement. But even if people came to the attention of law enforcement, we could make investments that would aid law enforcement in avoiding arrest in as many cases as possible. If arrest went forward, or if we had not become aware of a case until the point of arrest, there was still an opportunity to intervene at the point of initial detention while people were waiting for their first court appearance, or to even intervene with the court appearance to provide some kind of plan to the court and recommend some kind of diversion so that an individual would not end up jailed. And in our initial round of funding, and we've had 3 phases of funding, and we put detailed requests for proposals out to the field. I'm certain some of you on the call may in fact be grantees or have participated in responding to those RFPs. Most of the investments initially were at Intercept 1 and 2. As time has gone on with a second round of funding, what we call phase 2, and then a third round of funding, phase 3, we have made investments at Intercept 4 and at Intercept 0. And we even have one program that does work with probation as part of the program model. So really is involved with Intercept 5 in the hope, again, of avoiding recidivism for those class members. This framework, for people who are not familiar with it, is something that was developed by the Gaines Center for the Substance Abuse and Mental Health Services Administration, and has been used now for a number of years across the country to bring stakeholders together at the intersection of the criminal justice and public health systems and community safety to plan for community level responses to the number of individuals who are sadly ending up in jail instead of in community health and disability services that would better meet their needs and relieve pressure on jails who are not really organized and were never set up for the purpose of providing behavioral health and disability services. So we think this model has served us well. If we could move to the next slide, I've been talking a bit about the phase 1 and 2 RFP funds, but you'll see that the investments were in post-booking diversion services at Intercept Point 2, as I said earlier. And then we in phase 2, actually funded reentry services for a range of community supports, including treatment and case management services and housing, and providing flexible funds so people could put down first month's rent, last month's rent, the kinds of things that are required to be housed and that people in poverty rarely have available to them. And then you'll see here that in phase 3, we tried to build on work that the state had already invested in and a number of counties had invested in for crisis intervention teams, which are teams that the police have, and police being trained by mental health professionals and more recently by criminal justice professionals who've trained to do CIT, so they could train first responders in how to manage at the point of first response or at the point of a crisis, to resolve a crisis and channel somebody back towards the behavioral health or disability system rather than onwards towards the criminal justice system. And we were enhancing these crisis intervention teams by adding a co-responder to them, a clinician from a provider organization who could either ride along with or closely collaborate with police as they went out to calls to address crises in the community, challenges individuals were having, and again, to try to resolve those crises by getting people into care rather than into jail. Again, also further investments at Intercept Point 5, as I said before, about in community services, treatment, recovery supports, housing, and really addressing a lot of the social determinants of their health and disability conditions that really go to their fundamental poverty, so food insecurity and housing insecurity, among other things. But anyway, I want to move on now, if I could, to the next slide, which is a list of the providers who have been grantees under the 3 phases of the program. We have Catholic Charities of Central Washington serving Chelan County. We have Comprehensive Mental Health in Yakima, and they have 2 different grants in 2 different phases. We have Frontier Behavioral Health in Spokane. We have the Great Rivers Behavioral Health Organization, BHO, serving 5 different counties in the Great Rivers area. We have King County, which also has 2 grants. And then Kitsap Mental Health, Lourdes Mental Health, serving Benton and Franklin counties, and Pierce County. Pierce also has 2 grants in 2 different phases. And then the Thurston Mason Behavioral Health Organization, or BHO. So these providers, 9 different providers, have about 13 different programs or grants among them to serve class members. I'm going to turn this back over to Kim Mosoff, who's going to talk to you about some exemplary programs so you understand some more detail about the types of programs that have been funded. Thank you.
Okay, thank you, Dr. Mash.
And by the way, I guess I should pause for a moment to ask, are there any questions before we move on?
Thank you, Dr. Mosh. Yes, there are a couple of questions that came in. So Jim asks, is it okay to use some of the information on these slides and work to help regional partners better understand Trueblood? So clearly and succinctly described. Thank you.
Absolutely. We would really be very appreciative of your effort to do that. The broader the understanding of the objectives of these programs and the broader the interest and commitment, the more likely we are to be able to target class members effectively and to bring other resources online and services online that would meet our class member needs. We're also anticipating, and we'll talk about this later in next steps, another round of funding, and we'd like to generate as much interest from qualified organizations in the community as possible. So thank you for that.
Ronald asks, Are there sufficient incentives for police to do CIT training?
I would say that I don't know how one defines sufficient. I believe that the police find CIT very useful because they're being confronted with trying to be first responders to a group of people who, in my personal opinion, and this is nothing about Washington State, this goes back to my nearly 50 years working in the field and having served in several state governments and agencies and services in several states. I really think it's our responsibility in the health and public health and behavioral health field to be taking care of people. It's not the responsibility of the police. And yet they've been thrust, this responsibility has been thrust on them because of gaps in our own response as behavioral health professionals, for example, or disability professionals. And I think these are welcome trainings and supports. It is a challenge without funding for a police department or a sheriff's department to take this on because, you know, depending on which training curriculum you use, and really the gold standard is a 40-hour curriculum, you've got to figure out a way to release your officers to be trained for 40 hours while you still continue to carry out your public safety responsibilities. I think some counties have been able to use tax dollars and other resources to fund this. Some have been able to attract grants of one type or another, but I'm sure more resources would be appreciated and would really help to balance the interest in doing this with the financial and operating burden of doing it.
Thank you. Angela is asking that it's sort of I think more of a statement or a surprise is that there's no grant for Snohomish County. I know that there is some.
Well, I can respond to that. Snohomish County was one of the first grantees, and they had a grant for several years, but they were unable to sustain the grant and they withdrew. Sunrise Services was the provider. So they were actually one of the first grantees, and we, in subsequent rounds of funding, we have not had any applications from Snohomish County.
And then Amy is asking, can you tell us more about the funding for housing and if there will be more funding for people in the Trueblood program?
There will be more funding for people in the Trueblood program. And housing is a top priority. We recently fielded a survey with the assistance of Policy Resource Associates. Some of you on this call may well have responded to the survey. The survey was circulated to more than 100 people who are involved in, or individuals, probably a fewer number of organizations. I think there were 65 or more organizations between stakeholders in the justice area, the courts, the police and sheriffs, as well as providers of community-based services. And that survey is designed to better inform our deliberations around the next round of funding. Those data have not been yet analyzed, so we don't have the results of that survey, although the survey closed recently, and we had a very good response. But I can tell you that everywhere we go, and we'll talk about this a couple of slides later, housing emerges as the priority in every case. And housing is something that we have been addressing and we will continue to address. You know, I will say, without taking too much time here or digressing too much, that given the limited funds available and the time it takes to produce new housing, our investments have not been in building buildings or renovating buildings. The investments are more in making access to rental housing more affordable, in providing the staff resources to help people find and stay stable in housing, and to provide, as I said before, flexible funds that allow a program that's trying to house somebody and an individual who's seeking to be housed to actually get over the threshold, not only of paying rent and maybe having a subsidy for that rent, but paying for those first-time renter or first-time tenant costs that, you know, involve security deposits and material things you're going to need to be able to move in and live comfortably somewhere. Thank you.
And I think the last question before we move on was just could you tell the providers that are in Pierce County?
I'm sorry, could you repeat that? Could I tell the providers what?
Which providers are providing the contempt fine projects in Pierce County?
Well, the county itself is the recipient of the funds, and then the county effectively distributes or subcontracts the funds. So the county's the grantee, and they subcontract the funds to a number of different entities, including clinical providers and like comprehensive community behavioral health provider in the county, a substance use treatment provider in the county. They also provide some funds to a center that operates across from the courthouse that is a kind of resource center for people who are homeless and otherwise in need of a variety of things, from clothing to housing assistance to food security assistance, etc. And then there are some funds that go to entities in the county and the defenders and the prosecutors and others to have everybody working at the table on diversion planning for class members. Since it is the last question and I'm going to transition to Kim, maybe you'd want to comment further on the Pierce County model.
Yeah, sure. Thanks, Dr. Mash. In Pierce County, the main providers that the county contracts with, I think, are Greater Lakes to do a lot of the case management services for their program that focuses on trying to move folks out of jail, either through the Intercept 2 work or the release planning at Intercept 4. And then for the program that is looking at Intercept 1, the co-responder program, the county is working with, I think it's Multicare, who is responsible for the designated crisis responders. So they employ several DCRs through that program. I think those are the main subcontracted providers in Pierce County. Okay. So let's see. There we go. So we wanted to focus on a few of the programs and talk a little bit more about their work. So the first one we thought we'd hone in on is a program in King County. This was one of the first programs grants awarded through the Phase 1 RFP for the Legal Intervention and Network of Care. It's called the LINK program. This program identifies and screens potential clients who are post-booking, but prior to filing criminal charges. So in that sense, it's really a true sort of prosecutorial diversion model. They're working really hard to screen the cases that come in, and prior to that initial court appearance in front of the judge, to intervene and say, okay, we're going to do something instead of moving forward on this criminal case. So in lieu of prosecution, the provider, community house, mental health agency gets involved to provide behavioral health treatment, including outreach case management. For this, the case managers are really going out into the field. I mean, they are looking for folks wherever they may be. Sometimes, obviously, they may have to go into the jail, but you know, they're going out to meet with family and friends, to find them on the streets, to find them in their hangouts, and so it's a pretty resource-intensive case management model. Then they also provide legal coordination to meet existing court obligations and to avoid new charges. So for that case that they have, decided to divert, they have to continue communicating with the court or the prosecutor to some extent. But then they're also working, if something new happens, to try to avoid new charges being filed. They provide respite beds and residential supports, some other housing. They have a psychiatric AR&P on staff so that there's no gap in medication management and availability. They have a day treatment program, and then they have more recently added peer support services onto their model. So it's a pretty service-intensive program, and they've had a lot of success, I think, working with folks, keeping them out of jail and keeping them engaged. I think their initial model was for a 6-month intervention with folks, but that can be extended, and they found that it is very useful to keep folks involved for beyond the 6 months. And I wanted to just show, in response to the question about housing, we have tried to fund various housing interventions through all these programs. This is one of the respite housing sites for Link, where folks can go immediately and have a safe, supportive place to stay. Link has also opened some I should say bought, renovated, and now runs some longer term transitional housing in the north end of Seattle, where they have staff on site, I think 24/7, and those have been working out really well for them as well. So the second program I wanted to focus on is the Thurston Mason Behavioral Health Organization, which we funded in our phase 2. And this, their program also focuses on the intervention 2, but more the intervention for release planning. Individuals are referred and screened once they're in jail, so they don't tend to intervene prior to the initial charges being filed. Once a person is in jail, they can be sort of referred by anyone, I think most frequently, by the defense attorney or the prosecutor or by jail staff themselves. The Trueblood funded staff some of them are actually working and housed within the jail. And then staff work to promote the release from jail as soon as possible, including a warm handoff to their peer support specialists. The peer support specialists there do a ton of great work, and I think the program relies really heavily on their expertise. That person meets the individual while they're in jail, establishes that relationship, and then is there literally to pick them up once they're released, to take them to whatever emergency short-term housing might be needed, to provide the flex funds to get them their ID, to get them the bus pass, to drive them for intakes and appointments, and to really be there along the way. And I think technically those services are provided upwards of 90 days post-release, but that also can be extended. In the first year of this program, and we're well into the second, approaching third year, but in the first year, the program had enrolled 38 class members with the peer support services. They had diverted, 24% of those were diverted pre-trial, that Intercept 2. The majority, 76%, were enrolled at the Intercept 4 reentry point. They had gotten almost 50% of those people permanently housed, and upwards of 80% enrolled in treatment. So they've had some really good success getting people just stabilized. And the third program I wanted to highlight is one of our phase 3 programs that we, the co-responder crisis intervention team models that Dr. Mosh spoke about. And this is the LORDS program, which is in Benton, Franklin County. The LORDS program started a mobile outreach team to connect mental health staff with 9 different law enforcement agencies. So that's a pretty significant undertaking to work with that many different agencies with those many different needs, and to coordinate that in Benton and Franklin counties. The mental health staff work directly with the officers to prevent arrest and to connect class members with services. The mobile outreach team can also refer that person that they have an initial contact with. They can refer them to some peer support specialists that they have for follow-up and ongoing services. So not everyone will get that, but someone who might need more, who may not already be established in services, can get follow-up services and case management through the peer support specialists, including help finding housing, accessing treatment, and some of those other more immediate needs. And in the first year in the Lord's MOT had 94 contacts with former class members, 74 of which were diverted from likely arrest. And that's really the key that we're trying to get at in those phase 3 co-responder programs is, can you intervene, and in a situation where the officer has probable cause and would have likely arrested that person, can you show that not for the work of that mental health professional, that there would have been an arrest. And then the MOT also helped hundreds of non-class members, and I think this is a key point for our programs that are working at that Intercept 0-1 point. It's very difficult to figure out in the moment who is a prior class member, who's had competency restoration services in the past. That's very difficult to achieve. So those programs are just, by nature of the program, going to come into contact with a lot of different people in crisis, many of whom may not have an established competency restoration history, but would be likely to be entering into that forensic mental health system were it not for the intervention of the program. So even with that challenge, Lord's in its first year was able to serve almost 100 established former class members, in addition to the hundreds of others. And I want to show a short video here. Hopefully the audio will cooperate, but we talked about the use of peer support specialists throughout many of the programs. And I was talking specifically about in the Thurston Mason BHO and at Lord's, they have both used peers beautifully. And I think, we hear from all of the different stakeholders involved in those programs how key the use of peer support specialists is. And so I wanted to show a video here that came from our Trueblood Diversion Services Summit. That was a summit we convened in September of 2019. And so all of the different providers, Trueblood funded providers statewide, came along with their kind of criminal legal partners, came and met for 2 days to talk about all the different issues that they were encountering, to connect. And we had some videos that came out of that. We'll give this a shot, see if it works, and I'll let Melody let me know if the audio is not going to cooperate here, but this is just about a 4 or 5 minute video. Actually, let me ask Melody, are we almost at time at this point?
We actually are. We only have about 3 or 4 minutes left.
Okay, I'm going to skip the video then and just let you know that these are available on the Disability Rights website, and I can get that to Melody, the link, if you'd like to watch. I think these are really powerful. So I'm sorry we don't have time to see them now, but the 2 peer support specialists in this video are from the Thurston Mason program and the Lord's program. So I just would definitely recommend people take a look at that. There's some other videos that came out of that summit that might be of interest. All right, I'm going to turn it back over to Dr. Mosh to talk a little bit about monitoring in our last few minutes.
Thank you. I will speak quickly because people have these slides available to them so you can see, but I just wanted to state that in principle, Judge Peckman wanted these programs monitored, and we all felt that a keen sense of responsibility to ensure that these funds were spent on behalf of class members and also were spent responsibly to contribute to better conditions for class members and to really support compliance. And so we've been using a team of experienced people who had long careers in state government and county government in Washington, along with myself, who had 20 years in state government and many more years in organizations working on behalf of state and federal government to do the program monitoring. We're joined by Kim Mossoff and Daria Farivar from DRW in the monitoring. And for the first year, everybody's seen quarterly and then twice a year thereafter. And they submit quarterly reports on their the data points about the clients they're serving and the money they're spending, et cetera. If we look at the next slide, just to orient you, there have been several things that were really critical to success, and Kim has talked about some of these, so I just want to point them out to you. Intensive case management has been critical, and careful coordination between the criminal justice programs and the treatment partners. The use of peers, as Kim said, these flex funds that I talked about, and then access to mental health and substance use screening and treatment. And finally, housing. And we mentioned it 3 times, as the earlier question indicated. This is a very important issue. So I'm going to just skip quickly. The next slide talks about some of the challenges which have involved really trying to find and target class members, the lack of affordable housing, again, the housing theme, and then access to adequate treatment resources and getting all parts of the legal and criminal justice system on board. So finally, I want to just go to the last slide, next step. We have about a minute here, and say that we're working hard to determine the impact of these services for not only for reasons of accountability, but wanting to use it to inform how we go forward in spending the remaining fines funds. And then we're working hard to develop sustainability plans for each of the existing grantees. And we'll be, as I said before, executing phase 4 grants based on the planning work of the Diversion Services Workgroup. So I want to thank everybody for being with us today.
Dr. Mosh, Kim, thank you both so much for your time today and all of the great information. Again, these slides are available for download. I also included a document that sort of explains the difference between the contempt fines, the Trueblood settlement agreement, and the prosecutorial diversion programs that DSHS manages. Thank you both so much. This has just been very helpful, great information. There were a few more questions and comments, and I'll send those to Kim and see if or Dr. Mosh and see if they would like to respond to those. Again, thank you all so much for your time today, and have a great rest of May. So we'll hope to see you next month for our next webinar series. Stay tuned for the announcement for the next webinar series that'll come out probably the first part of June. Thank you all so much for your time today. Have a great day.
Thank you. Bye-bye.